Okay, we'll go live now. A very good evening to one of our present here who have joined us for today's session. I welcome you all to one more rapid revision series of GRASP 24. Today we have our most distinguished speaker, Dr. Kohila ma'am, Assistant Professor, Department of Anatomy, Madurai Medical College. It's an honor to have you, ma'am. Thank you. Today, ma'am will be taking about spinal cord and brainstem. Over to you, ma'am.
A very good evening to one and all. Thanks for that intro, Dr. Parthiban, and thanks for the opportunity, Dr. Raghunandan. Medicine has been doing a very good job for the past few years, helping students with the academic performance. And with the university exams with close proximity, right, coming up in August, we thought we'll go up with a rapid revision series in anatomy, discussing the key points that is expected in your university exam paper, your theory paper, and from external point of view, what is expected from your papers in your practical exams, right? So neuroanatomy today, we decided we'll go through a rapid revision about the importance of spinal cord and brainstem. This is going to be interesting because I'm not going to take a lecture or something, but from your side contribution, so that I thought it'll be more if we go like a question and answer discussion, MCQs, okay? And then we'll be discussing the clinical concepts. Neuroanatomy is at the end of your first year. You might be saturated, exhausted, right? But neuroanatomy, trust me, is the best part and interesting part of anatomy. Especially when you correlate it with physiology, you'll find it extremely interesting. If you understand the basic concept, right, you'll be able to apply it in your medicine long case also. Okay? So, yeah, it is interesting. It's easy. We are here to simplify it to the core. So to start with neuroanatomy, whatever lecture has been taken in your college, spinal cord, medulla, pons, midbrain, cerebellum, fourth ventricle, cerebrum, sulci gyri, functional area, white matter, thalamus, hypothalamus, basal ganglia, blood supply of brain. Everything, every topic that you see in your neuroanatomy first page, right? It is an essay question. It has been asked over the years. Okay. But all of you by now must have ticked the important questions, previous year questions. But the major difference is that for the past 4 years, we have been following the CBME curriculum, and you must have understood it's all like clinical oriented cases, isn't it? Okay, just one second. Clinical oriented cases. So the same question which appeared like 10 years before in the university, it will be there. It might come in your question paper university exam, but the only difference, it's going to be a case scenario. And from the clue, you have to pick it out. Okay, there will be cues, definitely cues in the case scenario. You should be smart enough to pick it out. So that's why I thought I'll take it more of a clinical oriented one. Okay. Yeah. So today it's going to be like around next 40 to 45 minutes we'll wind up. Yeah. So be with me till then. Because whatever point I'm going to tell will help you to write your essay, to arrive at a diagnosis of your essay, like what is given there in the case scenario, or presentation of your 5 mark question, and even answering your MCQs, because all that I'm going to tell is important points. And even your practicals, what is expected out of you in spinal cord and brainstem, I can help you with it if you're going to follow me. So we'll start right today. It's spinal cord and brainstem. Yes, you can see the image. Hope it's there. Yes. And can you see the structure that's pointed out? Yeah, what is it? It's easy, right? So definitely there's going to be one spotter from spinal cord or the cerebrum, the brainstem, cerebellum. One spotter from neuroanatomy, definitely you'll get that out of the 10. Okay. And if the spinal cord is kept, there are a few things which are standard questions in a spotter for spinal cord. And here you can see the blue arrow pointing at the spinal cord, right? Yeah. So what is the level of the termination of the spinal cord in adult? In adult, it corresponds to, you can enter the answers in the chat box. In the adult, the level of termination of the spinal cord corresponds to lower border of L1, right? There are so many events taking place at L1. What is that vertebral plane? L1, transpyloric plane. In abdomen, you must have learned, right? The hilum of both the kidneys, the origin of superior mesenteric artery, the pylorus of the stomach, the formation of portal veins, so many things, right? Everything related to L1. Okay, so the spinal cord terminates in adults at the lower border of L1. Okay, whereas in children, in newborn, right? L3. Okay, like similar things. The level of termination of the dura mater. Yes, you can tell me. Come on. The dura mater and the arachnoid. It terminates at the level of, yes, 2. Pia mater is going to terminate at the level of first coccygeal vertebra. Also remember the subarachnoid space, that also S2. Okay, so the level of termination, yeah, it is important for your spotter question. Apart from that, okay, what are the other spotters? So you told me this is, yeah, the tapering part is the termination of spinal cord. If I put an arrow above this, yes, that also they'll do. What is this part? You should be able to answer it as conus medullaris. If I put a pin below that, okay, I'm going to tie this thin, glistening, white, filament-like structure, which continues below the termination of the spinal cord. What is that? That is called the phylum terminale, the modification of the pia mater that covers the spinal cord. Okay, another one spotter for you here. You can see these bunch of nerves here. The bunch of nerves here, what is that? Yes, so in your university exam spotter, they'll tie this bunch of nerves with a thread, and the question will be asked. Identify the tight structure. What does it contain? Yes, you're right. It is going to be chorda equina. And what does it contain? Can you list it out? Yes, it has the lower lumbar nerves, the sacral nerves, and the coccygeal nerves. L2, L3, L4, L5. The lower four pair of lumbar nerves, the sacral nerves, S2, S3, S1, S2, S3, S4, S5. And how many coccygeal nerves are there? One pair of coccygeal nerve. So these are the contents of chorda equina, right? So these are all standard questions in the spinal cord specimens in your spotter. Another one, which of the following is not a modification of the pointed meninges? Yeah, so that is the ligamenta denticulata. So you can see the spinal cord here. This transparent membrane in close proximity with the spinal cord. Yeah, but this transparent ribbon with tooth-like projections from its lateral margin, it's called the ligamenta denticulata. Okay, ligamenta denticulata. So it is a modification of which meningeal layer that covers the spinal cord? The pia mater, right? So yes, they'll ask you, identify what is it a modification of? What are the other modifications of the same? So you'll identify it as ligamenta denticulata, right? And it's a modification of pia mater. What are the other modifications of the pia mater? So let me draw you a schematic representation of the spinal cord. Right. So spinal cord, you have the outer white matter, inner gray matter. What are the horns of the gray matter? You'll see the posterior gray horn, anterior gray horn. Any other horns there? Yes, lateral gray horn. Where do you get to? Which section of the spinal cord you get to see the lateral gray horn? In the thoracic region, thoracolumbar and over S2 to S4. Okay, so they have the neurons for the autonomic nervous system. In the thoracolumbar region, it's for the sympathetic, and S2, S3, S4 will have the parasympathetic, the lateral horn in the spinal cord, right? Okay, yeah. Now, again, you know, the dorsal horn is sensory and the anterior gray horn is motor. Now, this pia mater, which is going to cover the spinal cord, okay, it is going to have some modifications. You know, this is the anterior aspect, posterior aspect. So on the anterior aspect, the pia mater, it gives a septum that extends into the anteromedian fissure. And where that septum arises, that part of the pia mater is thickened on the anterior surface. It's called the linea splendens. Linea splendens on the anterior aspect. Similarly, on the posterior aspect, okay, surrounding the pia mater, we have the arachnoid and the dura, right? So on the posterior aspect, the pia mater, again, it sends a septum. Okay, it goes and attaches to the, the arachnoid. Sometimes it can pierce the arachnoid and attach to the inner surface of the dura. It's called the subarachnoid septum, right? And on the lateral aspect, we have the ligamenta denticulata. And on the lower aspect, we have the phylum terminale. So what is the purpose of all these modifications? You know, the spinal cord ends at L1. It's going to be surrounded by the subarachnoid space, which has the CSF, isn't it? So to anchor the spinal cord within the vertebral column, these pia mater, okay, they extend all throughout the spinal cord and anchor it within the CSF, okay? Yeah, so lower down, it's anchored to the dorsal surface of the first coccygeal vertebra by phylum terminale. Laterally, we have the ligamenta denticulata and anteriorly linea splendens, posteriorly subarachnoid septum, right? And another spotter that they can keep in the spinal cord is this one. What is this? This is the dorsal root ganglia, isn't it? The dorsal root ganglia. And what type of neuron does it contain? It has the pseudo unipolar neurons. Okay, so these are the standard spotter questions in the spinal cord. Again, clinical importance of the spinal cord. So during lumbar puncture, what is the level of the lumbar puncture? Can you you can tell me? Yes, the spinal cord ends at lower quarter of L1 and the best place to put a needle to withdraw CSF. Yes, in lumbar puncture is L3, L4. So you don't injure the spinal cord. Okay, you'll just have the roots, the cauda equina there. And okay, the next question related to this. During lumbar puncture, after piercing which structure, the needle will enter in the epidural space. So what is the epidural space? Outside the dura mater. Okay. So outside the dura mater, which ligament is going to be related here? Yeah. I'll just show you here with a picture, explain it. You see the vertebra there? Yeah. So this is the anterior surface, posterior surface. Whenever any image, you know, these are the vertebra. With a massive body, you can make it out. It's the lumbar vertebra and anterior, posterior. Identification is easy. Anteriorly of the body, posteriorly the spinous process, isn't it? Now coming to the ligaments, you might have confused with the names. If not, okay, good. Okay, so you see the spinous process covering the tip of all the spinous process. Can you tell me what ligament is this? That's the supraspinous ligament. Okay, now I'll take another color. Now in between the, yes, the spinous process, you get to see another ligament. What is this ligament? It's the interspinous, between, right? Interspinous ligament. Now, you know there's a pedicle and the lamina on the inner aspect of the lamina, okay? On the inner aspect of the lamina, you get to see another ligament. There's another better picture I'll show you, okay? Next slide. This is the ligamentum flavum. Okay, so yeah, that is the vertebral column that you see here, right? The anterior surface of the body of all these vertebra, they are connected by another ligament. Yes, you have the anterior longitudinal ligament. This is the vertebral column here. The posterior surface of the body, they are connected by a ligament, the posterior longitudinal ligament. So you can see the space here. Okay. That is the intervertebral foramen. And here, okay, you can see here, this will be the vertebral. Sorry, 1 second. Laptop charge. Excuse me a minute. Yeah. So here, this is the vertebral canal where you're going to get to see the spinal cord. Okay. So as I showed you in the previous picture, Anterior surface of all the bodies are connected by anterior longitudinal ligament. And here posterior surface of the body, posterior longitudinal ligament. You can see the supraspinous ligament here connecting the tip of the spinous process. Yeah. And this is the interspinous ligament. You can make it out. This one is the ligamentum flavum. Okay. So when you enter the ligamentum flavum, your needle is you're going to enter the epidural space. Yeah. So you want to inject some anesthetic fluid to provide epidural anesthesia, you can just put your needle there. Okay. But in case you want to proceed further to collect the CSF, then the needle has to pass through the epidural space, the dura mater, the subdural space, the arachnoid mater, and then enter the subarachnoid space. So if you want to collect CSF in the lumbar puncture, okay, what are the structures or the order the structures appears by the needle? Okay, just remember this mnemonic. Sleepy Sarah slept in lab after dining asparagus. Okay, asparagus is not heavy as your biryani, right? Yeah, but just for a mnemonic purpose. So it's going to be skin, the structures pierced by the needle while you're going to take CSF. Okay, so skin, superficial fascia, supraspinous ligament, interspinous ligament, ligamentum flavum, and then comes your epidural space, dura mater, subdural space, arachnoid mater. You enter the subarachnoid space to withdraw the CSF. Easy? Okay. You might have an OSPI chart, right? With lumbar puncture. Yes, it is very important. The level of lumbar puncture and the structure spears. Coming to the most interesting part of spinal cord, the tracts it is very, 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 very important. Okay, so you know, right? So anterior gray horn, posterior gray horn, and lateral gray horn. You must have learned about the nuclei in the anterior gray horn, right? The groups of nuclei. Yeah, you have the phrenic nerve nucleus, the ventromedial nucleus, right? And yeah, the lumbosacral nucleus, all that. Similarly, lateral gray horn, I told you, sympathetic nucleus and parasympathetic. Posterior gray horn, you must have learned about yes, the substantia gelatinosa, nucleus proprius, Clark's column, visceral afferent nucleus, all that. Okay, you should be knowing. And what is there in the white matter? The tracts, the ascending tracts and the descending tracts. Yes. So before going to the question, can you help me identify them? Just a few of the ascending tract. I'll mark it A, B. The ascending tracts here in this image is shown in blue color. Again, you know, this is anterior, this is posterior, right? So yeah, A, B, C, D, E, and F. Are you with me? Come on. Help me identify. So what is A? A is anterior spinothalamic tract. B is lateral spinothalamic tract. C and D are anterior and posterior spinocerebellar tract. E is fasciculus cuneatus. F will be fasciculus gracilis. And both together we call it as the dorsal column or the posterior column. Am I right? Yes. You must have learned it in your neurophysiology and neuroanatomy, isn't it? So this is very, very important. The identification of the tracts. Right. So you'll be able to identify. Now coming to the question. Patient presented with loss of pain and temperature over his right leg. Okay. Now the name of the tract, the location of the tract, and what is the next thing you should know? The function. Can you tell me the function of these few tracts? Anterior spinothalamic tract is going to carry what sensation? Touch and pressure. From which part of the body? From the trunk and from the limbs. The next thing, the very next thing you should be able to tell me, whether it's a crossed or uncrossed tract. It is crossed. So why are we worried about whether it's crossed or uncrossed? So if there's a lesion of the right side spinothalamic tract, patient is going to present with loss of pain and temperature over the left side of the body, right? Contralateral, okay, crossed. Coming to lateral spinothalamic tract, that is concerned with carrying pain and temperature. Again, from the trunk and the limb, and this is also crossed. Okay, this is very, very important. Okay, contralateral. And coming to anterior and posterior spinocerebellar tract, what information do they carry to the cerebellum? Proprioception. Okay, from the joints, the movements of those joints, unconscious proprioception, and anterior spinocerebellar tract is uncrossed, posterior is crossed. Okay, and another MCQ related to this spinocerebellar tract is that the posterior spinocerebellar tract, spinocerebellar, it reaches the cerebellum through the inferior cerebellar peduncle. Whereas the anterior spinocerebellar tract, it reaches the cerebellum through the superior cerebellar peduncle. And another MCQ, both these tracts, they carry that proprioceptive information from which part of the body? Exclusively from the lower limbs. Okay, and a chocolate question. The same information to the cerebellum from the upper limb is carried by which tract? Can you tell me? This sense of unconscious proprioception from the upper part of the body, from the upper limbs, is carried to the cerebellum by, yes, anyone? The cuneo-cerebellar tracts. You have the accessory cuneate nucleus in the medulla, remember, from there. Okay, now coming to the dorsal column pathway, you must have done in your physiology practicals, right? So first thing to remember, it is going to carry from the same side of the body, ipsilateral. Ipsilateral. What are the sensations carried by this posterior column pathway? Yes, discriminative touch, 2-point discrimination. Yes, stereognosis, vibration, proprioception. And fasciculus cuneate is the same thing from the upper limb and the upper trunk. And fasciculus gracilis from the lower limb and the lower trunk. Okay, so here it's just, I just want you want to know whether you've understood. So loss of pain and temperature from the contralateral leg. Pain and temperature, which tract did we saw? We saw it's the lateral spinothalamic tract. Okay, contralateral. Okay, now this you'll do it. Patient presented with loss of discriminative touch over his right upper limb. So discriminative touch, we saw it's concerned with which tract, which ascending tract? The posterior column. But more specific, if they've given you two options, fasciculus gracilis and fasciculus cuneatus, which one would you like to prefer? Come on, waiting for your answers. From the upper limb, right? Yes, it is going to be fasciculus cuneatus, right? And ipsilateral. So the lesion is on the right side. Moving on to the next question. Identify the spinal cord lesion with poliomyelitis. Can you tell me? I'll just label. This is A, this is B, this is C, and D. Okay. So which one is you're going to match with poliomyelitis? So what happens in poliomyelitis? Which part of the spinal cord is affected? You know, the patient is not able to move, right? Moves limbs. Yeah. So it is motor or sensory. Motor neurons are present where? In the ventral gray horn or posterior gray horn, dorsal gray horn? In the ventral gray horn. Okay, so poliomyelitis, that virus, it typically affects the motor neurons in the anterior gray horn. So this shows the, yeah, poliomyelitis. What is this? Yes, anyone? You see a lesion, that blue color is the disease part, okay? It's involving the central canal of the spinal cord. It's involving the anterior gray horn. And what is this region called exactly in front of, like, again, posterior to the anteromedian fissure? It's called the anterior commissure. What happens here? Crossing, right? I told you anterior spinothalamic, lateral spinothalamic are crossing. So the crossing of the spinothalamic tract takes place there. So yes, can you tell me what condition is this? It's the syringomyelia. I put a separate slide to explain that. What happens in syringomyelia? A cavity develops within the central canal of the spinal cord and just goes, yes, expands, and it involves the deposition, the crossing of the spinothalamic tract. So what will be lost? Of course, pain, temperature, touch, pressure, everything, okay, both. But remember, it's because the crossing is involved, bilateral loss, okay? Yeah. And then coming to this one, a few word about the blood supply of the spinal cord. Okay. So, the blood supply to the spinal cord is from the spinal arteries, anterior spinal artery, posterior spinal artery. Anterior spinal artery and posterior spinal artery, a branch of the vertebral artery. The anterior spinal artery, it supplies anterior two-third of the spinal cord. And the posterior spinal artery, posterior one-third of the spinal cord. So if there's an occlusion of the anterior spinal artery, okay, then the anterior two-third will go for infarction. And what is preserved in anterior spinal cord syndrome? The sensations, the sensations carries in the posterior column is preserved. Okay. And here this is the occlusion of the posterior spinal artery. So posterior spinal cord syndrome typically affecting the posterior column. Okay. And even in syphilitic lesion, tabes dorsalis, the posterior column will be involved. Right? Yes. So what should know about the tract is that you should know the name of the tract, the location of the tract in the white matter, and the sensations carried by it, whether it's crossed or uncrossed. Okay. Yeah. So this is what I told you, syringomyelia. You can see that yellow color is the lesion, a cavity developing. Yeah. And most of the time, like the fibers, yeah, of the upper part of the body is involved. So there'll be bilateral loss of pain and temperature or pressure and touch over the upper limb, yeah, and the upper trunk region that gives a cape-like distribution. Whereas the other sensations carried by the posterior column, yeah, discriminative touch, vibration, proprioception, all that will be present. Okay, only this in the spinothalamic tract will be affected. And this is what I told you in syphilitic lesion, tabes dorsalis. Okay, it specifically involves the dorsal column. Yeah, so here again, the sensation carried by the dorsal column in the dorsal column will be lost. And since proprioception is gone, you ask the patient to walk in a straight line with closed eyes. He will stumble, and this is called as the Romberg sign. Okay. Again, bilateral. Yeah, here syringomyelia is again bilateral. Brown-Sequard syndrome. Yeah, you must be thorough with it, right? The hemisection of the spinal cord. Hemisection. Okay. So here, at the level of lesion, everything is gone. Sensory and motor, lower motor neuron. Below the level of lesion, upper motor neuron type of spastic paralysis. And because of involvement of posterior column, what happens? On the side of lesion, ipsilateral loss of proprioception, vibration, stereognosis, two-point discrimination, discriminative touch. Because of the spinothalamic tract, what will happen? On the contralateral side, loss of pain and temperature. Okay. So what is shown in red color here is the paralysis ipsilateral side. Same ipsilateral side, that stripes that you see, that is because of the involvement of the posterior column. And on the contralateral side, loss of pain and temperature. At the level of lesion, it's always element, okay, loss of motor and sensory symptoms. So that is all about the spinal cord that I wanted to highlight to you. Okay, so spinal cord, yes, the tracts are important. The blood supply of spinal cord is important. Okay, and spotter wise again, definitely spinal cord will be kept, and the questions are standard ones. Whatever we discuss only will be there. Coming to the brainstem. So what are the components of the brainstem? So brainstem, what I'm going to discuss with you, I'll just tell you, okay? So we'll be discussing the features on the ventral surface and the features on the dorsal surface. And then we'll be doing the cross section and then the clinical anatomy of the brainstem. Everything in a, like as you saw now, right? MCQ type, okay? Yeah. Now, what are the parts of the brainstem? That's the medulla, the pons, and then the midbrain, isn't it? Now, the blue arrow. injury to the pointed structure will result in. Can you tell me what is the structure pointed here? Yes. You can keep entering in the chat box. You can just tell me what is the structure pointed that. It is a nerve, right? Yes, I'm just trying to open the chat box. What nerve is that you see here?
இந்தியாவோட மோஸ்ட் எக்ஸ்பெக்டட் ஜாபான ரயில்வேஸ் எக்ஸாம் நோட்டிஃபிகேஷன் வந்துருச்சு. ஐஏஎஸ்
Sorry,
காலி பணியிடங்கள் அப்படி அறிவிச்சிருக்காங்க.
I'm trying to get your answer in the chat box. Yeah, I'm not able to see you. What nerve is that? Yes, you can keep entering.
There will be 10 seconds lag, I think, ma'am, in YouTube and Zoom. That's why the replies will be late.
Okay, I'm not able to see the answers. Okay, maybe I'll just keep it. Okay.
Okay.
So the pointed structure is the which cranial nerve? Okay, just one outline about the brainstem and its ventral surface. So this is the medulla. Guys, these are the basic things that you should definitely know. Basic things. Like you cannot attend a theory exam or a practical or even touch a patient or read any report without knowing these basic things. Okay. Yeah, so that's the medulla. This is pons, and this is the region of midbrain. Right. What are the cranial nerves related to midbrain? 3 and 4. What are the cranial nerves related to pons? 5, 6, 7, and 8. What are the cranial nerves related to medulla? 9, 10, 11, and 12. Okay. So this basic idea you should be knowing so that we can build up on the rest. So medulla, if you see, medulla is going to continue below with the spinal cord. So the anterior surface of the medulla will somewhat look similar to the spinal cord, only upper part, especially the dorsal part, will has to open up to contribute to the fourth ventricle. So this is the anteromedian fissure. Top is the foramen cecum, and this anteromedian fissure in the lower part, it sorts of fades because of that motor decussation you see here. Right. And then this is the anterolateral sulcus, similar to your spinal cord. This is the posterolateral sulcus. Now, in your spotter exam, they can put a pin here. They can put a pin here, right? So this bulge that you see on either side of the anteromedian fissure, it's the pyramid. So you know what they'll ask you? They'll put the pin on the pyramid, identify. You'll tell it's pyramid. What lies underneath? What lies underneath the pyramid? Come on. Yes, it has the corticospinal fibers. Right. So pyramid, the bulge is produced due to the underlying corticospinal fibers. And I told you at the lower end, it's going to cross. So if there's a lesion of the pyramid, lesion of the corticospinal fibers above the crossing, okay, above the crossing, then the feature hemiplegia will be on the opposite side, okay, above crossing. If it is below the crossing, then it will be on the same side. You understood? Once it is crossed, then the same side hemiplegia. Before crossing, if the fibers are involved, then it will be contralateral hemiplegia. That's about the pyramid. Now coming to the anterolateral sulcus. I see it's some message. Okay. So here, just lateral to the pyramid, you can see another bulge. That's the olive. So they'll put the pin there and they'll ask you, identify. And what lies underneath? We have the inferior olivary nucleus, right? You have the inferior olivary nucleus underneath it. Okay. And yeah, so okay with the pyramid and olive. Now coming to the anterolateral sulcus. They can put the pin on the anterolateral sulcus. They can ask you, what is it? It is the anterolateral sulcus. And the nerve emerging at the anterolateral sulcus, what is that nerve? This is going to be the hypoglossal nerve, right? The hypoglossal nerve. And what is there in the posterolateral sulcus? The nerves that you see emerging from the posterolateral sulcus. This is the ninth nerve. This is the 10th and this is the 11th one. Is it visible over here? 9, 10 and 11th. You can see the spinal accessory nerve joining the cranial accessory. Okay. Yeah. And just lateral to it, we'll have the inferior cerebellar peduncle. Okay. And this is the pons. Yeah. So, okay. Now, the pointed structure is the hypoglossal nerve. Okay. Paralysis of the muscles of soft palate. What is the nerve supply to the muscles of the soft palate? Pharyngeal plexus through the vagus or cranial accessory. Muscles of the tongue. You can tell me all the muscles of the tongue are innervated by hypoglossal nerve except all the muscles of the tongue are innervated by hypoglossal nerve except palatoglossus that is innervated from the pharyngeal plexus. Paralysis of muscles of lower limb will take place if there's injury to the pyramid, right? And muscles of face if the facial nerve is involved, and that's not related to the medulla. Okay, so which one can we circle as the right answer? B. Okay with me? Yes. Yeah. Now, ventral surface of pons, structure that lodges in the pointed area. So this is the pons. Where is the pointer exactly on the pons? So ventral surface of pons, if you see, this groove is called the basilar groove. And what lodges that? The basilar artery. How is the basilar artery formed? So you have the right and left vertebral artery, which then unite to form the basilar artery. What are the branches of basilar artery? The basilar artery will give rise to antero-inferior cerebellar artery, lot of branches to supply the pons, which we call it as the pontine branches. And one of them will go and enter the internal acoustic meatus to supply the inner ear, called the labyrinthine artery. And then we get the superior cerebellar artery. And the termination of the basilar artery is the posterior cerebral artery. Right? So this is all about basilar arteries. Okay, over here. Now, what is this nerve? This is the emergence of the fifth nerve, the trigeminal nerve, is the thickest of all the cranial nerves. The stoutest, the widest of all the cranial nerves is the trigeminal nerve. So that is the trigeminal nerve you see here. It has a motor root and a sensory root. Which one is small, which one is large? This is the motor root. This is the sensory root. So the part of the pons that you see just lateral to the emergence of the trigeminal nerve, that's the middle cerebellar peduncle. Okay, so they can put the pin anywhere in the pons, over the basilar groove, over the trigeminal nerve, or over the middle cerebellar peduncle. Now, at the junction of the pons with the medulla, you see the sixth nerve, either side of the midline. You see the seventh nerve, and this is the eighth nerve. So the cranial nerves at the pontomedullary junction is 6, 7, 8 from medial to lateral. Is that fine? So we have seen the ventral surface of the pons. Coming to the next thing. Injury to the pointed structure will result in. Excellent, Dr. Sanjit, Tarun. Very good, very good, very good. Keep answering. So what is pointed out here? So we are done with pons, we have done with medulla, now we are going to midbrain. What are the cranial nerves related to midbrain? 3 and 4. And what nerve, which cranial nerve could be pointed out? Yes, this one is the third nerve, so this is the fourth nerve. The fourth nerve, again an MCQ, is the only cranial nerve that exits from the dorsal aspect of the brainstem. Okay, so you're saying this is the ventral surface of the brainstem. We saw every nerve coming from the ventral surface, right? But this fourth cranial nerve is the only one which exits from the dorsal aspect of the brainstem. Okay, that is one MCQ. So, what is the other name for the fourth nerve? Trochlear nerve. What muscle does it supply? It supplies only one muscle that winds around that pulley, right? The trochlea in the orbit. The superior oblique muscle. What are the actions of the superior oblique muscle? You need superior oblique to depress. Depress. The obliques will abduct both the obliques and intorsion. Okay, so it helps the eye to turn down and out. So injury to the pointed structure will result in inability to turn the eyeball down and out. Okay, so ptosis is due to caused by paralysis of levator palpebrae superior supplied by third nerve. External squint, Paralysis of medial rectus, again innervated by the oculomotor nerve. Internal squint. You want to look out, but the eye goes medially. Paralysis of lateral rectus, innervated by the sixth nerve. Okay, so we have covered so many MCQs in this one question. Now on the, so that's the right fourth nerve palsy. Not able to turn the eye down and out. You want to read a book, you want to read a newspaper, you want to walk down the stairs looking down, right? Yeah, you need the trochlear nerve superior oblique for that. If the trochlear nerve is injured, if the superior oblique goes for paralysis, and you try looking down, oh my God, your eyes are not looking down, okay? You get a diplopia, you'll not be able to read. You don't know where you put your leg in the step. Diplopia is there, right? Okay, so that's the midbrain. Yeah, this is the crus cerebri or the cerebral peduncles. It has three components. We'll be looking into it. This is the third nerve. This is the fourth nerve. Okay. And that's the region of the interpeduncular fossa. You see the optic chiasma, the optic tract, the mammillary body, the tuber cinereum with the pituitary stalk, the posterior perforated substance. Interpeduncular fossa because it lies between the cerebral peduncles of both the sides. Is that fine? So far we have covered the ventral surface of medulla, pons, and midbrain in a question format. Now coming to the dorsal surface of the brainstem. The pointed structure contains, yes, Tarun, Sanjit, Manish, come on. Sibi, come on, yeah. So we are looking to the medulla from the posterior aspect, isn't it? Yes. Can you tell me what is it, what is pointed out? So what was there on the posterior aspect of the spinal cord? We saw the dorsal column, right? Fasciculus gracilis, fasciculus cuneatus, the dorsal column. The same thing we are seeing here. Okay, so this is the fasciculus gracilis. This is the fasciculus gracilis. This is fasciculus cuneatus, right? So fasciculus gracilis and coming and ending in the nucleus gracilis. This is nucleus cuneatus. It's called the gracile tubercle and the cuneate tubercle. And you must have learned in physiology, this is an essay question, right? Dorsal column pathway, posterior column pathway. So, you know, there are three set of neurons, the first order neuron, second order neuron, and the third order neuron. The third order neuron, it actually lies in the thalamus. The first order neuron is always the dorsal root ganglia, right? For most of the ascending tract. And the second order neuron for the spinothalamic tract, spinocerebellar tract, it lies in the posterior gray horn. Okay, but for the dorsal column pathway, the second order neuron, it lies in the medulla, right? In the nucleus gracilis and the nucleus cuneatus. The second order neurons are there. And the axons that begin from the second order neurons, they form the medial lemniscus. And this medial lemniscus will end in the ventro-posterolateral nucleus of thalamus. So dorsal column pathway is an important essay question, lot of MCQs there. The first order neuron, dorsal root ganglia. Second order neuron in the medulla, nucleus gracilis and nucleus cuneatus. Third order neuron, ventro-posterolateral nucleus of the thalamus. And remember, till medulla, it's going to be like ipsilateral side. But what happens in the second order neuron, the axons, they cross over and form the medial lemniscus. So injury to medial lemniscus, the posterior column sensation, but on the opposite side of the body. Got it? Okay. Coming to the next bit, okay. So that is your fasciculus gracilis, fasciculus cuneatus, okay. And just lateral to it, this is the inferior cerebellar peduncle. And here in the lower part, the upper part, like it opens up to form the fourth ventricle. What is that you see here? Fourth ventricle, guys, remember it's an important essay question. So again, this is the hypoglossal triangle, which has the hypoglossal nucleus and the nucleus intercalatus. Below that, okay, hypoglossal triangle. Below that, this is the vagal triangle, which has the dorsal nucleus of vagus and the area postrema, which has the chemoreceptors for vomiting. This is the inferior vestibular area. You know, there are four groups of vestibular nucleus: superior, inferior, medial, and lateral. The lateral nucleus is also called the Dieter's nucleus. Just additional information. Okay. Yeah. Coming to the next thing. the pointed structure contains. Can you just first tell me what is the pointed structure? Yes? Come on, Tarun, Sanjit, what is the pointed structure? The pointed structure is the facial colliculus, right? The pointed structure is the facial colliculus. What is this facial colliculus? This facial colliculus is situated in the lower pons, okay? What you see here, I just want to show you three nucleus here which are shown in three colors. This is the spinal nucleus of trigeminal nerve. This blue color is the motor nucleus of the facial nerve, and the red color is the abducens nucleus. So what happens, the muscles of the face are innervated by face, if you see, the muscles are innervated by the seventh nerve, whereas the skin over the face is innervated by the trigeminal nerve, isn't it? Okay. And if the both the nucleus are close by, for example, if you see this is the corneal reflex, you touch the cornea, the afferent is by the ophthalmic division of the trigeminal nerve. And the efferent is the, you close the eye, contraction of orbicularis oculi innervated by the facial nerve, right? So closure, efferent component is by the seventh nerve. Okay, this is the blink reflex. So to establish quick reflex, there's migration of the motor nucleus of the facial nerve towards the spinal nucleus of the trigeminal nerve. This phenomena of migration is called as the neurobiotaxis. Okay, so as it migrates, what happens? You can see the blue fibers, right? The axons of the facial nerve winding around the abducens nerve nucleus. This produces a bulge. Okay, this winding around, the turn of the facial nerve is called the internal genu of the facial nerve, right? Or the motor fibers of the facial nerve. So the two components that make up the facial colliculus is the abducens nerve nucleus and the motor fibers of the facial nerve or the internal genu of the facial nerve. Is that okay? Yeah. So that is what you see here, the facial colliculus on the dorsal surface of the pons contributing to the fourth ventricle. Yeah. Again, what could this be? Easy. Yes, Sanjit, Tarun, are you there? Sibi? Is the audio video okay? Any issues in the net connectivity? So what is the structure pointed out here? This is the posterior surface, the dorsal aspect of the midbrain, isn't it? So what are the things you get to see here? This is the superior colliculus. This is inferior colliculus. This is the pineal gland. This is the region of the third ventricle. The third ventricle lies between the two thalami, right? The third ventricle is a midline structure that lies between the two thalami. You can see the pineal gland. This is the region of the midbrain. The two superior colliculi and the two inferior colliculi together they form the corpora quadrigemina, and that's the cruciform sulcus separating the colliculi. Okay, right. So this nerve that you see here on the dorsal aspect of the brainstem. Yes, what is it? Below the inferior colliculi? Very good, Manish. Yeah, excellent. That's the trochlear nerve. And what muscle does it supply? Superior oblique. Okay. So I just showed you an image. You'll get an orientation of it. Okay. It's very important. Yeah. Coming, okay, we have done with the ventral surface and the dorsal surface. Now moving on to the cross section, easy, okay? So yeah, like each of the brainstem is an essay question. Medulla is an essay question, pons and midbrain. I put the case scenarios at the end after the cross section. Only if you understand the cross section, you'll know what is inside the brainstem, right, medulla. So I thought discussing the clinical anatomy at the end will be of more useful. Which of the following is not seen in this cross section? So this is the cross section of the medulla. You can see the olivary nucleus. What do you know about nucleus ambiguous? Nucleus ambiguous, the axons coming from the nucleus ambiguous, they contribute to 9, 10, 11 cranial nerve that supplies the muscles of soft palate, pharynx, and larynx, right? The fourth and the sixth arch, vagus, right? Okay. Ninth is the third arch nerve. Okay. Nucleus ambiguous. What do you know about nucleus tractus solitarius? Taste sensation. It receives the taste sensation. So taste sensation from the fungiform papillae. Anterior two-third of the tongue is seventh nerve. Taste sensation from the circumvallate papillae, ninth nerve. And taste sensation from the posteriormost part of the tongue in the region of the vallicula is 10th nerve. Spinal nucleus of trigeminal nerve. So trigeminal nerve, we know it's going to innervate the skin of the face. And the spinal nucleus, it receives pain and temperature. What about this red nucleus? What do you know about the red nucleus? Is it situated in the medulla? No. Where do you find the red nucleus? The red nucleus is situated in, waiting for your answers, midbrain. Okay, so this red nucleus, it receives information, it is motor, okay, it is motor. It receives information from the cerebellum, from the globus pallidus, the basal nuclei. And the efferent fibers from it, they go to the spinal cord, okay, so it mainly controls the movements. So when you study medulla, you'll be studying cross-section of medulla, 3 levels. One is the motor decussation, that is at the lower. Okay, you saw the anteromedian fissure fading out. And sensory decussation. And this is the olivary level at the upper part. Okay, you can see it's opened up to form the floor of the fourth ventricle. So the lower medulla looks like similar to a spinal cord, right? And now I'm not just going to take a lecture on the entire thing. I'm just going to tell you the key points, okay? So what is definitely expected out of you? You're definitely supposed to know it. So the lower medulla, if you see, it looks more like of a spinal cord, outer white matter, inner gray matter, anterior gray horn, posterior gray horn. Okay, but just few differences that you should know. The pyramid we saw, right? This is the anteromedian fissure. Either side we saw the pyramid. So the corticospinal fibers there in the pyramid, they cross over. They form the lateral corticospinal tract. The cross fibers, they form the lateral corticospinal tract, whereas the uncrossed fibers will lie there to form the anterior corticospinal tract. Because of the crossing, what happens? The anterior gray horn sort of gives a detached appearance. It will have the nucleus for the spinal accessory nerve and the ventral ramus of C1. Okay. And the second thing, if you go behind, this is the posterior aspect. What do you see in the posterior aspect of the spinal cord? Fasciculus gracilis cuneatus. The same thing that you see here, this yellow color, right? Fasciculus gracilis, fasciculus cuneatus. But here you can appreciate it's coming and ending over the nucleus gracilis, nucleus cuneatus. For me, it looks like the ears of a rabbit, bunny's ears. Nucleus gracilis and nucleus cuneatus. And another, just lateral to it, is another important one, the spinal nucleus of the trigeminal nerve, which you'll see in medulla, also in the lower pons. Okay, its location is very important, laterally, posterolaterally. Spinal nucleus of the trigeminal nerve and the tract overlying it. So these are the things you should definitely appreciate in a motor decussation. Coming to sensory decussation. So it's not like outer white matter, inner gray matter. The gray matter is dispersed. So what are the things that are expected out of you here? You see the nucleus gracilis, nucleus cuneatus, and make a note of it. That is the situated close to the nucleus cuneatus is the accessory cuneate nucleus. And again, a spinal nucleus and tract of trigeminal nerve. Now, something interesting going to happen here. The axons from the nucleus gracilis and cuneatus, you can see them moving forward and decussating with the opposite side to form the medial lemniscus, the posterior column pathway. So that's why it's called the sensory decussation. And these fibers are called the internal arcuate fibers. Okay. And you can see the central canal of the spinal cord, now central canal of the medulla. So this gray matter surrounding it's called the central gray matter, which will have the hypoglossal nucleus, the dorsal nucleus of vagus, nucleus tractus solitarius. So yes, this is important. Yeah, coming to the section of medulla bit above, okay, where you see it's opening up to form the dorsal surface of the fourth ventricle, contributing to the fourth ventricle. Okay, so this is the pyramid. Lesion of the pyramid, contralateral hemiplegia. In front of the pyramid, this yellow color that you see there is called the arcuate nuclei. The fibers arising from it will give rise to the anterior external arcuate fibers. Internal arcuate we saw, right? The sensory decussation, the axons of nucleus gracilis and cuneatus. This is anterior external arcuate fibers, okay? And then, okay, you can see the medial lemniscus. You can very well make out the olivary nucleus. Yeah, the principal olivary nucleus, okay? Apart from that, yes, you can make out the hypoglossal nucleus either side of the midline, the dorsal nucleus of vagus, the nucleus tractus solitarius, the spinal nucleus. I told you to observe the spinal nucleus, its position, right? Spinal nucleus of the trigeminal nerve. One more important thing, the nucleus ambiguous, the position of nucleus ambiguous, and the appearance of vestibular nuclei. So all this should be in the diagram if it's asked for a 5-mark question. Okay? Yeah. So what are the cranial nerve related to medulla? 9, 10, 11, 12. And the nuclei of 8 you see both in the upper medulla and lower pons. Is that okay? Okay. Now, coming to pons, cross section of pons. Which of the following nucleus of the trigeminal nerve? It's not seen in the cross section of lower pons. Easy, important. Waiting for your answers. Come on. Tarun, Janet, Manish, Sanjit, Sibi. Yes, you know the trigeminal nerve is the fifth cranial nerve. It has 3 components, ophthalmic, maxillary, mandibular. And yes, within the brainstem, there are 4 sets of nucleus. The spinal nucleus of the trigeminal nerve is present in the medulla and lower pons. Motor nucleus in the pons, upper and lower. Chief sensory nucleus also in the pons. The mesencephalic nucleus, it's present there in the upper pons and entire midbrain. Okay, so yeah, this will be the answer. Now coming to the next important thing about this nucleus. The spinal nucleus, very good, Tarun. The spinal nucleus, what type of sensation it receives from the face? Pain and temperature. You feel hot, cold, right, from the face? Yeah, someone pinching you on the face, something. Okay, it's scary. It reaches the spinal nucleus. Motor nucleus, the muscles, the 4 muscles of mastication. Can you tell me what are they? Masseter, temporalis, medial pterygoid, lateral pterygoid. The 2 tensors, tensa tympani, tensa palatini, and then anterior belly of digastric and mylohyoid. 8 muscles are innervated by this motor nucleus. The chief sensory nucleus receives touch and pressure. The mesencephalic nucleus, it receives proprioception from the temporomandibular joint, from the muscles of mastication, from the muscles that move the eyeball. Okay. Another interesting thing is that it has unipolar neurons, pseudo-unipolar neurons. And in that proprioceptive pathway, it forms the first order neuron. Okay, so these are the MCQs related to the mesencephalic nucleus of trigeminal nerve. Right? Okay, so pons, you'll be learning the cross section at 2 levels, lower pons, upper pons. Pons, if you see the cross section, the anterior part of it is called the basilar part, where you see pontine nuclei and then some longitudinal fibers. What is the black dots? Those are the cortic coming from the cerebral cortex. Corticopontine will synapse in the pontine nuclei. Other than that, you'll have the corticospinal, corticonuclear fibers. And then the horizontal fibers going through the middle cerebellar peduncle, those are the pontocerebellar fibers. So the basilar part of the pons, it remains constant, whether it's the lower pons or upper pons. Coming to the posterior aspect of the pons, it's called the tegmentum. Only the tegmentum you get to see few changes. Okay. In the anteriormost part of the tegmentum, you get to see the trapezoid body. What is this trapezoid body? It's nothing but the efferent fibers from the cochlea nuclei. There are two cochlea nuclei, ventral and dorsal cochlea nuclei. Vestibular nuclei, how many did I tell you? 4, right? Superior, inferior, medial, lateral. Cochlea, there are two, ventral and dorsal cochlea nuclei. So these efferent fibers from the cochlea nuclei, they form the trapezoid body. And yes, they form part of the auditory pathway. So the other thing that you should remember in lower pons is especially this facial colliculus. We talked about that. In the upper pons, what are the cranial nerve related to pons? 5, 6, 7, 8, right? So lower pons, 6, 7 nucleus and vestibular cochlear nuclei. Upper pons, you see the fifth nerve nucleus, the motor nucleus and the chief sensory nucleus of the trigeminal nerve. Okay? Come on. Injury to which of these structures in the midbrain will cause contralateral hemiplegia? All of these are parts of midbrain only. Come on, waiting for your answer. Janet, Tarun, Sibi, Manish, people, are you there? Injury to which of these structures in the midbrain will cause contralateral hemiplegia? So what are the parts that you see in the cross section of the midbrain? Yes, midbrain cross section is very easy to identify because you see the cerebral aqueduct, right? This part is called as the cerebral peduncle. There are three components for the cerebral peduncle. What you see, the anterior most is the crus cerebri. Then you have the substantia nigra, and this part is called the tegmentum. So in the crus cerebri, you'll have the fibers, okay, of which, yeah, it can be a spotter for you. The middle two-third of it has the corticopontine, corticospinal, corticonuclear fibers. The medial one-third has the frontopontine, and the lateral part has the fibers coming from the rest of the cerebral cortex, from the other lobes, paritopontine, occipitopontine, temporopontine. Okay, arrangement of fibers in the crus cerebri is important. And then we have the substantia nigra. Anterior part is called pars reticularis, posterior part is called pars compacta. What does it contain? The neurons have dopamine as the neurotransmitter. And what do you have in the tegmentum? The lemniscus, the medial lemniscus, the trigeminal lemniscus, the spinal lemniscus. And at the upper midbrain, we'll have the lateral lemniscus also. Okay. So crus cerebri, involvement of the crus cerebri, the corticospinal fibers will produce contralateral hemiplegia. Involvement of substantia nigra will produce Parkinsonism, right? And tegmentum, you have the medial lemniscus. It's nothing but the part of the posterior column pathway. Spinal lemniscus, again, the spinothalamic tract, right? And trigeminal lemniscus, the sensation from the face, but that's going to be crossed. Spinal nucleus and tract of trigeminal nerve, the lesion will be ipsilateral. Trigeminal lemniscus will have cross fibers, okay? And lateral lemniscus, it's part of your auditory pathway, okay? Yes. And tectum is this region that you see behind the cerebral aqueduct. It has the superior colliculus and inferior colliculus. Superior colliculus, it's concerned with visual pathway, visual information. Inferior colliculus, again, auditory pathway. What are the cranial nerve related to midbrain? 3 and 4. Okay. So cross section of midbrain will be at two levels. The lower midbrain or at the level of inferior colliculus. Upper midbrain at the level of superior colliculus. Okay. So the cranial nerve that you see here at the inferior colliculus level will be 3. And superior colliculus, I'm sorry, it's exactly the reverse. The inferior colliculus will be 4, superior colliculus will be 3. Okay, so yeah. So this is the crus cerebri, substantia nigra. You see the lemniscus, medial, trigeminal, spinal, and lateral lemniscus. Lateral lemniscus will end at the inferior colliculus. Lateral lemniscus and inferior colliculus components of the auditory pathway. So lateral lemniscus you will not see in the upper midbrain at the superior collicular level. Okay. And another interesting feature, this is the cerebral aqueduct. This gray matter surrounding the cerebral aqueduct we call it as the periaqueductal gray matter, where you will see trochlear nucleus. And irrespective of whether upper or lower midbrain, you will get to see the mesencephalic nucleus. Can you see? The mesencephalic nucleus in the periaqueductal gray. Okay, so remember that. And can you appreciate the axons of the trochlear nerve? What's happening? It's going all around the periaqueductal gray matter. It decussate posterior midline, right? And exits from the dorsal aspect of the brainstem. Okay. Another feature that you see here is the decussation of the superior cerebellar peduncle at the inferior collicular level. Going to the superior colliculus level, the important thing that you should see, this is the superior colliculus, right? And just in front of it, you can see the pretectal nucleus. The pretectal nucleus is responsible for the light reflex. Yeah. So you show a torch, the pupil goes for constriction, a direct light reflex, and on the opposite eye also the pupil constricts, consensual light reflex, isn't it? Pupillary light reflex. It's because of the intact pretectal nucleus. Okay, so superior colliculus, you get to see the superior colliculus, the pretectal nucleus, and there's not going to be any lateral lemniscus because it has ended in the inferior colliculus. And here, third nerve, oculomotor nuclear complex. What is the parasympathetic nucleus of the oculomotor nerve? Edinger-Westphal nucleus is also present here. It's a part of that oculomotor nuclear complex. And in the tegmentum, you'll be able to appreciate the red nucleus. Any idea why is it called red nucleus? Why does it appear so pinkish? Yes, because of the presence of lot of iron and melanin in those neurons. And you'll get to see the ventral and dorsal tegmental decussation. Okay. So yeah, so these are the features of the cross section of the midbrain. This ventral tegmental decussation will be the fibers of the red nucleus. Red nucleus, remember we have seen, right? It's motor, I told you. It's receiving information from the cerebellum, from the globus pallidus and giving to the spinal cord. Okay, and the dorsal tegmental decussation is again from the superior cerebellar peduncle. Okay, yeah. Now, coming to the most important part. Are you there, guys, with me? Yes. Now you're going to help me pick out. So we saw about the spinal cord, we saw about the brainstem features on the dorsal ventral surface in the cross section. Now you should be able to apply and get the answers. Oh, I have any case scenario you get. Okay, so pick out for the clues there. One, you should be able to identify the side of the lesion, and with the cranial, with the clues given, you should be able to identify whether what is there, or whether it's a cranial nerve nucleus, or it is any tract or lemniscus, which is involved. Okay, so yeah, the clues in this case scenario I've just given it italic font, okay, so that we'll be able to identify. Have you read it? Okay, 57 old women, dizziness and nystagmus, it clinches towards the eighth nerve, giddiness, everything. And loss of pain and temperature sensation over the right side of the face and left side of the body. Left side of the body, loss of pain and temperature is going to pin to the, yes, which tract? Spinal nucleus and tract of the trigeminal nerve, isn't it? Right side of the face, ipsilateral. So this case, it's going to be right side. Okay, this over the right side. Yeah. And loss of pain and temperature over the left side of the body, it's going to be the spinothalamic tract. Spinothalamic tract, left side of the body. So the lesion is going to be on the right side. Pain and temperature from the trunk and the limbs. If it's from the face, it will be spinal nucleus and tract of trigeminal. Okay. And then coming to the next clue. Yeah. Ataxia, intentional tremor, it all points towards the cerebellum or the cerebellar peduncles. Okay. The next clue, hoarseness of voice related to the 10th nerve. Yes. And this one, pupillary constriction, drooping, face becoming drier. It's all Horner syndrome, pointing towards the sympathetic fibers in the reticular formation. So what do you want to conclude? Yes? Yeah? So which part of the brainstem is it? You see 8, 10, spinothalamic, it's going to be medulla. Which region of the medulla? Dorsolateral medulla. What is this syndrome called? It's called as the lateral medullary syndrome or the Wallenberg syndrome or else the pica syndrome, because the dorsolateral zone of the medulla is supplied by the postero-inferior cerebellar artery, a branch of the vertebral artery. Occlusion of this artery, this area can go for infarction. So as I told you, involvement of the eighth nerve, giddiness, nystagmus, and involvement of the nucleus ambiguous, paralysis of the muscles of soft palate, pharynx, and larynx, involvement of the spinal nucleus and tract of the trigeminal nerve, loss of pain and temperature over the face, involvement of the spinothalamic tract, contralateral loss of pain and temperature, involvement of the sympathetic fibers, Horner syndrome. What are the components of the Horner syndrome? Meiosis, ptosis, enophthalmos, S, anhidrosis. Okay. Yeah. One word about medial medullary syndrome. So this part is going to be supplied by the anterior spinal artery. Involvement, occlusion of the anterior spinal artery, then the paramedian region of the medulla will go for infarction. So what do you see here will be mainly the pyramid will be there, the medial lemniscus, and the 12th nerve emerging out. So there'll be paralysis, ipsilateral paralysis of the tongue. If it's the right side, if it's the right side infarction, then the right half of the tongue, those muscles will go for atrophy and the tongue will deviate to the same side. Pyramid, contralateral hemiplegia. Medial lemniscus, against cross fibers of posterior column. So loss of vibration, proprioception, discriminative touch, stereognosis, 2-point discrimination on the opposite side, on the left side. Got it? So these are the two important syndromes related to medulla. Then coming to Pons, heard about this syndrome? Millard-Guebler syndrome. Millard-Guebler syndrome. So it involves the sixth nerve, seventh nerve, and again the corticospinal fibers in the basilar part of the pons. So sixth nerve, what will happen? What type of squint? Lateral rectus. You want to look out, but it turns in. So ipsilateral medial squint. And seventh nerve, again, ipsilateral facial palsy. Corticospinal tract involvement, contralateral hemiplegia. Okay, Millard-Guebler syndrome in Pons. And another thing, the CP angle. What is CP angle? Cerebellopontine angle. Okay, why are we worried about it? What are the structures there? So the seventh nerve, the eighth nerve, and the flocculonodular lobe of the cerebellum, the choroid plexus, all that is situated there at the junction of the cerebellum and the pons. So what is very common in the clinical scenario is that the Schwann cells that cover the cochlear nerve, okay, a tumor arising from the Schwann cells that cover the cochlear nerve, it's called the acoustic neuroma or schwannoma, is a very common thing. Okay, so it can affect the other structures around the CP angle, the seventh nerve, the eighth nerve, all that. So ipsilateral facial palsy, and because of involvement of the vestibulocochlear nerve, patient is going to present with giddiness, nystagmus, hard of hearing, all that. Okay. So this is the picture to show you. Yeah, this here, it's everything same color, but here, this one. Can you appreciate here? A tumor of the CP angle, right? So seventh nerve, eighth nerve mainly involved. Next question. A 60-year-old male, okay, known diabetic, known hypertensive, all that, but what is the symptom? Ptosis and external squint of the left eye, right-sided hemiplegia. What could be the probable diagnosis? So ptosis and external squint. So Horner syndrome, that ptosis is different. Here you see like external squint of the left eye. You want to look in, but the eye is turning out. Okay. So that is due to involvement of the third nerve. Okay. Hemiplegia. Again, are corticospinal fibers. So what are these syndromes? Just now we saw Millard-Gubler syndrome, so it's not related. Third nerve related to the midbrain. And all these three syndromes that you see, they're related to midbrain. What is Weber syndrome? Weber syndrome, okay? The oculomotor nerve and the crus cerebri is involved. So what are the features of oculomotor nerve syndrome? I'll just give you a clue or mnemonic, okay? PED, make the A silent and L. Oculomotor nerve palsy. Ptosis, external squint, uh, dilated pupil, loss of accommodation, right? Why does ptosis occur? Due to paralysis of levator palpebrae superioris. Levator palpebrae superioris is the only elevator of your upper eyelid. It opens the eye. Paralysis of that ptosis. External squint due to paralysis of medial rectus. Medial rectus will adduct the eyeball, right? Paralysis of that external squint. Dilated pupil, that Edinger-Westphal nucleus, parasympathetic nucleus, right? The parasympathetic fibers of oculomotor nerve is going to innervate. Yes. Sphincter pupillae, which is responsible for constriction of pupil, and ciliaris muscle, which is responsible for accommodation. Okay. So paralysis of these two muscles, you get a dilated pupil and loss of accommodation. Weber syndrome, third nerve, and contralateral hemiplegia due to involvement of the corticospinal fibers in the crus cerebri. Benedict syndrome. So this typically involves the tegmentum of the midbrain along with the third nerve. So third nerve features we have seen. What are the structures present in the tegmentum? Medial lemniscus, I call MTSL. Okay. So medial lemniscus, posterior column but cross. So contralateral laws of proprioception, vibration, stereognosis, 2-point discrimination, discriminative touch. As you keep telling only, you'll memorize it, okay? Trigeminal lemniscus again, sensation from the face but cross fibers. So contralateral laws of pain, temperature from face. Spinal lemniscus again, anterior and lateral spinothalamic tract. So contralateral laws of pain, temperature, touch pressure from the limbs and trunk. Lateral lemniscus part of your auditory pathway, isn't it? So these are features of the Benedict syndrome. Now, can you tell me what syndrome is this? Yeah? Any idea what is it? It's again midbrain. Here there's lesion of the superior colliculus. Okay, so this is the pineal gland. A tumor of the pineal gland can compress the superior colliculus and the person will have difficulty in looking up. The upward gaze is frozen. This is called as the Parinaud syndrome. Okay, Parinaud syndrome. And last, yes. What is Argyll-Robertson pupil? Where is the lesion? So in the Argyll-Robertson pupil, the light reflex is lost, but the accommodation is present. Okay, just please remember here the lesion is in the pretectal nucleus. Okay, the pretectal nucleus is responsible for the light reflex. Lesion of the pretectal nucleus. This nucleus is situated in front of the superior colliculus, I told you. Yes, so the light reflects, the pupil will not be constricting, but the accommodation is present. Okay, so yes, today's session I'll wind up. Yeah, so we have tried to summarize for the past 1 hour about the spinal cord, the important spotters in the spinal cord, the tracts, and the spinal cord syndromes, isn't it? And brainstem, we just went in detail. We saw about the features on the ventral and the dorsal surface and cross-section of medulla, pons, midbrain, and the clinical syndromes related to brainstem. Okay. Yes. So what I've tried to summarize it is the important points, the key points expected from you as a student in your examination, whether theory or practical. Hope this session was useful. Any doubt, you can again get back to the team. Yes. Thank you. Do share us your feedbacks, right? Thank you, guys.
Thank you so much, ma'am. That was a very wonderful session. And I think in the recent times, we had the highest viewership for today, ma'am. Almost 250 members have watched it live.
Oh, really?
Live
Thanks,
stream.
Parthiban. Thank you, thank you.
That was a very amazing session, and we are expecting more and more sessions from you, ma'am.
Definitely. Okay. We can get the feedback from the student side, like what, like neuroanatomy is really interesting, and I love teaching neuroanatomy because the basic understanding will help you to not only cover your exams, but also in your medicine cases, it will be very helpful,
Yes, ma'am.
right? So what the next class we can get from them what topic they want, and we can discuss.
Hmm.
Thank
Okay.
you, Medicine, for the opportunity.
Oh,
Thanks.
I
Thank you, Ravi.
hand over it to Dr. Raghunandan.
Yes, please.
Anna, 1 minute, I'll call.
Thank you, ma'am. Thank you so much, ma'am. It was really a wonderful session today. And I hope that many people would have been listening to the session and it would be benefited to everyone. And I have seen many people who were constantly answering your questions also in the chat box. Tarun, Sanjit, Manish Ilangovan, and many others were like answering. Today, there was some issue in the live number of count, ma'am, live count in the YouTube. I don't know why. But then around 250 students have been seeing so far, and it would have been benefited to everyone, I guess, ma'am. Thank you once again for joining with us today, ma'am. It was really a wonderful session, and hope we will see a more revision series and many videos for the students of 2023 batch, ma'am. Thank you.
Thank you, Raghu. Thanks, Parthiban. Thank you, medicine team. Thank you, students. We'll keep doing the same. Thank you.
I've just updated the description with the feedback form. Ma'am requires a feedback of all yours. So do at the end of the session, do kindly give you a wonderful feedback so that it will be like encouraging ma'am a lot.
Thank you.
Okay, we'll wind up. We'll close the session. Thank you.